Hello everyone. So welcome to this Opthal Images Decoded session. So we are going to discuss 10 or more images here. So let's start. Are you all ready? Okay, so the first image is this. Okay, so this is our first image. So what can you see here? So this is an image of OCT, yes, optical coherence tomography. Now OCT, as I've already told you, is used to visualize all the layers of the retina, the posterior vitreous, yes, the posterior part of the vitreous, the retina, and also the choroid. So what do we see in this image? See, you can see a full thickness defect in the retina. Can you see a big gap in the retina? Yes. So that is a full thickness macular hole. Okay. So that is a macular hole, right? So this is a macular hole, OCT showing macular hole. Now, could you have guessed the diagnosis based on the options? Let's see the options. One is vitreomacular traction. See, vitreomacular traction would have something coming from the vitreous, a band trying to pull the vitreous. Okay, so there will be a traction, meaning a pull. Okay, a vitreomacular traction. So this is not vitreomacular traction. In fact, I've discussed that with you. The second option is macular hole, which in fact is the diagnosis. Agree with me? Is this macular hole? A full thickness defect in the retinal layers. Now option C says cystoid macular edema. Now some of you were confused. Now you saw these cysts and thought it was cystoid macular edema. These are intraretinal cysts. Okay. So when there is a macular hole, there can be intraretinal cysts. This is not a cystoid macular edema. When we say cystoid macular edema, there is no hole. Okay. The macular thickness itself is elevated and there are cysts in the outer plexiform layer. Yes. What was the last option? Subretinal fluid. Now subretinal fluid I'll show you on another day. So definitely now you know this is a macular hole. Don't get confused by these little tiny cysts which are there in the walls. Yes, those are the intraretinal cysts. Those are not characteristic of cystoid macular edema. Is that clear? Everyone agree with me? All right. Now, the next one. This is very simple. What is this clinical finding? What does this image show? What is this clinical finding? What is it? Type in the comment section, guys. Type in the chat box. What is this? What is this clinical finding? Do you even need options for this? Because this patient is going to come to you in the clinic, even if you're working in the PHC or you're a general practitioner or you're a medicine person, you're a pediatrics, especially if you're a pediatrician, you're going to come, patients are going to come to you with this kind of a finding. And they're not going to come to you with options, no? And you would still diagnose it. Won't you diagnose it? It's so easy. This one is so easy. Yes, what is the diagnosis? You want me to read out the options? Pterygium, scleromalacia perforans, pinguicula, Bitot spot. Pterygium, yes, is that a pterygium? Pterygium is a fleshy, pinkish or is little vascular or a fibrovascular mass, and it has to cross the limbus to call it a pterygium. Now, a pinguicula will look like a drop of butter. This definitely doesn't look like butter. So, this is not pinguicula. Scleromalacia perforans is where your sclera is so thin that you can see even the underlying uvea, giving it a somewhat bluish color to that area. The sclera is so thinned out and it's a little bluish. So, it's not that. So, it is Bitot spots. Where do you see Bitot spots, bache? Bitot spots you see in vitamin A deficiency. Okay, in the X1B stage of vitamin A deficiency. What stage? Staging given by World Health Organization. WHO stage X1B. You see these Bitot spots. So this is one version, one phenotype of Bitot spot. Yes, clear? So for some odd reason, the examiners have kind of some fixation over this Bitot spots of late. So even very, very easy questions like Bitot spot seen in, not even an image-based question. So even that is being asked. Now the next image is this. We've already discussed this image. So what is this instrument? What is this instrument, guys? Let's see what exactly is the question. This instrument is used to see all except. Okay, so for that I need to know what this instrument is. So this instrument is a gonioscope. It's a Goldman one mirror gonioscope. There's only one mirror, okay, one shisha. So it is Goldman's one mirror gonioscope. So gonioscope is used to see all except. Option A, corneal nerves. Can I see corneal nerves using gonioscope? No, not at all. I think that is the answer. But anyway, let me read option B. Option B, peripheral anterior synechiae. Yes, to visualize peripheral anterior synechiae and to classify your primary angle closure, whether it's a suspect or angle closure or an angle closure glaucoma, I need to see peripheral anterior synechiae, and for that I need gonioscope. So yes, I needed to see option B. Option C, sample SE's line. What is sample SE's line? Sample SE's line is a very prominent or a highly pigmented highly pigmented Schwalbe's line. And how do you see Schwalbe's line? Schwalbe's line is one of the components of your angle structures. Yes or no? How do you see your angle? Angle is seen using gonioscope. And where do we see sample SE's line? Typically, the best answer is pigment dispersion glaucoma. Okay, in pigment dispersion syndrome or pigment dispersion glaucoma, we get to see sample SE's line. If at all, there's another, because that was the one which was typically described. If you want another answer, then probably even pseudo exfoliation. Okay. Option D, KF ring. Kayser-Fleischer ring, to see a very, very early KF ring. The most sensitive thing is a gonioscope. You can see the very early deposits of copper on Descemet's membrane. That is the Schwalbe's ring. You can see on gonioscope. So this instrument, which instrument? This Goldman's gonioscope, to be very specific, one mirror gonioscope, cannot be used to see corneal nerves. So for corneal nerves, probably if you want to see, you can see it on a confocal microscopy. Okay, confocal microscopy, you can see corneal nerves. But are corneal nerves normally visible? Why do we need all these extra fittings or extra investigations to see them? Because the corneal nerves are unmyelinated. Yes, they are unmyelinated free endings. So we can't see them and we need a confocal microscope to see them. Okay, now the next image. All right, so let's take a look at this image. So this is a typical picture of a blepharophimosis epicanthus inversus syndrome, BPES. So why do I call it blepharophimosis? Blepharo means lid. The lid is drooping, as well as the horizontal length of the palpebral fissure is decreased. So it appears very constricted. The eye appears very constricted. Yes. So there is ptosis, bilateral ptosis. So you see the palpebral fissure height decreased and the length also decreased. And you can see the epicanthus inversus. So what is this epicanthus? Epicanthus means this extra skin fold on the medial canthal region. Now when I say epicanthus inversus, it means it arises from the lower lid. So the skin fold arises from the lower lid and goes up. Okay. So this is BPES. So let's see what is the question exactly. All of the findings are seen in this patient except. That means all of the findings are seen in blepharophimosis epicanthus syndrome except. Option A, increased interpupillary distance. See, I've told you the other day, they have telecanthus, increased distance between the two medial canthi, but the interpupillary distance is normal. So I've already got my answer, but anyway, let's check. Telecanthus, yes, we have telecanthus. So what is telecanthus? The distance between the two medial canthi is increased. However, the interpupillary distance is normal. Okay. So telecanthus is present. Epicanthus inversus, yes, very much present, defines the syndrome itself. Decreased palpebral fissure height, yes, whenever we have ptosis, the palpebral fissure height is decreased. What is palpebral fissure? This distance or this height space between the lid margins, the upper lid and the lower lid margins. Yes, when my eye is ptotic, obviously the palpebral fissure height will decrease. Yes or no? Yes. So the answer is in blepharophimosis epicanthus syndrome, which is this kid. Yes, there is no increased interpupillary distance. Interpupillary distance is normal. Is that clear? Okay. Can we move to the next image? All right, can we move to the next image? All of you, any of you have any questions here? Okay, the next is this image. This image is pretty simple. It shows you a CT scan with a coronal cut. And what do you see? This side, I'm seeing orbital floor. There is an interruption, meaning there's a fracture. And there is a prolapse of the orbital contents into the maxillary sinus below. Alright, so that is your typical teardrop or your water drop sign. So clinical finding expected to be seen in the patient. So what is the diagnosis here? So there is a blowout fracture. So in blowout fracture, what is the typical finding we expect to see? Lid lag. Do you see lid lag? No, we see lid lag in two conditions. One is thyroid eye disease and other is congenital ptosis. Typically lid lag on down gaze, not in blowout fracture. Lag of thalamus. What is lag of thalamus? Lag of thalamus is inability or inadequate closure of the eyes. So if I attempt to close my eyes and see, if both my eyes I'm closing and this eye is little open or wide open, whatever. So that is lag of thalamus. Okay. So inadequate or incomplete closure of the eyelids. So that is not present in blowout fracture. Upper lid retraction. Upper lid retraction you will see in thyroid eye disease very, very characteristically. Not here. Ophthalmos. Ophthalmos is typical of congenital glaucoma where you have a bull-like big eyes. Okay, not here. Enophthalmos. Yes, enophthalmos is a sunken eyeball. Why the eyeball will sink? Because when you have a blowout fracture like this, the orbital volume, that is 30 ml, some of it has gone down. So the eyeball will sink into the orbit. Yes, so a sunken or a depressed eye or a sunken eyeball is enophthalmos, which is seen in blowout fracture. Okay. Now let's take a look at the next image. This I've already discussed once and it's so beautiful. So you see the sago grain, these cobblestone appearance. Can you see the pavement stone appearance and this mucus sitting there? So this mucoid discharge, very, very sticky discharge, ropey or stringy discharge which has coagulated on everting the eyelid. So I see a pavement stone appearance because of the giant papillae, also called as a cobblestone appearance, and the Maxwell-Lyon sign, so which is very typical of. So the question is, the clinical finding is seen in, you don't even need an option, but anyway, let's see. Ophthalmia nodosum, no, it's a reaction to caterpillar hair, not that. Flictinular conjunctivitis, this is not flictin. Spring catarrh, yes, it is vernal keratoconjunctivitis because you're seeing the giant papillae. Yes, can you see the giant papillae giving you the cobblestone or pavement stone appearance and the mucoid discharge here? Yes, the Maxwell-Lyon sign. So this is vernal keratoconjunctivitis or spring catarrh. Yes, very simple, no, very easy one. Now this image, guys, this image is so very important. I've already discussed once previously. So you can see the target sign where you can see the deposits on the anterior lens capsule. Yes, a central deposit, a little bit of clearing, and again a deposit. So this is very, very typical of pseudo exfoliation. Okay, and pseudo exfoliation is the most common cause of secondary open angle glaucoma. Yes, it's very, 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 very easy question because we've discussed it so many times. Now look at this image. What can you see? You can see the conjunctiva stained green because we've applied lissamine green topically. Lissamine green we've applied topically and it has stained the dry conjunctiva, the dry epithelial cells. Yes. So this, let's see what is the question. The image shows, okay, Stocker's line, no, there's no pterygium at all. First of all, there is no pterygium and Stocker's line will be seen on the cornea, an iron line. So this is a conjunctiva which is stained green. So this is not Stocker's line. Episcleritis would be red in color. No. Intercalary staphyloma. Do I see anything bulging at the limbus? No. It's a conjunctiva which is stained green. So what is this? This is lissamine green staining the dry eye. So what is the correct answer? Option D, dryness of conjunctiva. Okay. So this image shows dryness of conjunctiva because the lissamine green is staining the conjunctiva. Is that clear? Okay. Now next question. Okay, look at this. There is a main air bubble and there are two bubbles here. Let's see what exactly is the question. The image shows. The image shows penetrating keratoplasty, intracorneal ring segments, intracameral SF6 pneumoretinopexy. What is pneumoretinopexy? I put a gas in the vitreous to attach the detached retina. If I'm putting gas there, you will not see gas in the anterior chamber. You will not see that. It will be in the vitreous. It won't be visible like this. So definitely this is not pneumoretinopexy. Okay. Now, intracorneal ring segments, I've put another video. I'll share the link later. So it is not intracorneal ring segment. Definitely not. And how does a penetrating keratoplasty look like? A penetrating keratoplasty is going to look like this, somewhat like this, because you will have sutures to keep the graft in place. Yes, you will have sutures to keep the graft in place. This is a fresh keratoplasty, so it's a little boggy, those tissues, but there are no sutures at all here, so it cannot be a full thickness or penetrating keratoplasty. Guys, you understand the difference? You understand the difference? Do you see the sutures all around to keep the graft in place in a penetrating or full thickness keratoplasty, whereas this one, it's just a gas bubble in the anterior chamber. In the anterior chamber means intracameral. Yes. So intracameral SF6, which we usually put a 14% sulfur hexafluoride. So for decimate membrane detachments or to manage your acute hydrops in keratoconus. Yes. So this is not penetrating keratoplasty. You definitely know this is not ICRS or intracorneal ring segments. Definitely not pneumoretinopexy. It is intracameral SF6. Yes. Yes. Sulfur hexafluoride. Intracameral bubble. Alright. So it could be an air also. It could have been, but I have given SF6. And another question was blue dot cataract. What is this image? This image shows, you see multiple dots away from the visual axis. You're seeing a dilated pupil. So this one is a punctate or a blue dot cataract. So the options that were given to you were actually what were the options? Zonular cataract? No, zonular cataract will be like a cart wheel of a cart. It will have a wheel-like appearance, a central disc and spokes from there. So it is not zonular cataract. Cuneiform cataract will have peripheral wedges. These are just dots. Okay, these are just dots. Rubella cataract will be a very pearly cataract, or it can be a very membranous appearance. Okay, total cataract. Blue dot cataract, also known as punctate cataract or cataracta ceruleum punctata or cataracta punctata ceruleum. Okay, blue dot cataract. So we have seen more than 10 images today. So I hope you're confident in these 10, 11 images that I have discussed with you today. Yes, guys, any doubts in these questions and these particular images that I have described or discussed with you today? Alright, so today evening we have at 6 p.m. we have Oftal frequently asked questions. Is that okay? I hope you're finding the discussions useful for you. See you guys. And there is a Christmas offer that we have started. It will be ongoing for the next 1 week or so. So on the EyeMentor app, there's a huge discount so that you can prepare for your university exam. Your university exam dates have been announced, so we've made sure that you have it at affordable rates for your preparation, and for NEET PG as well, and for the Oftal residents, for everyone. And we are adding more course material on the residence course. Okay, so see you guys, see you tomorrow 11 a.m. Bye bye.